everyone with an interest in NASH, or more broadly, fatty liver disease? Surf's Up, Season 3, Episode 40 of Surfing the NASH Tsunami. Our look at best practices for diagnosing and treating patients with lean NASH starts now.
This week on Surfing the NASH Tsunami.
There are definitely nuances in taking care of people that are lean. Because, our standard approach of diet and weight loss needs to be thought about in this particular context.
This is the difference between a straightforward document on your conventional typical NAFL patients versus those lean. You have really to pin it down, make sure that you're not missing something else.
The other thing that you went beyond where everybody else does is the recommendations of reviewing the FibroScan or MRI. It was 6 months to 1 to 2 years, depending on the level of fibrosis. That to me is important because when we look at non-lean NASH, those recommendations of 3 to 5 years are a little bit long.
Okay, I'll be controversial. I believe that the reason that the 3 and 5 year recommendations are given is because it is an effort to calm the fears of people, most of whom are payers in some way, shape, or form. That if we test this every year, oh my gosh, what does that tell us about what it's going to cost, what we're going to find, blah, 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 blah. Not necessarily through a patient-centric window.
The biggest thing that I see clinically is patients who come and say, oh yeah, I was told I had fatty liver disease, and then my doctor did an ultrasound, and then they said I'm good. And, what is that supposed to mean? You're good? Done, check box, forever?
The first thing is take this seriously, which has 2 elements to it. Number 1 is think more expansively about what patients might be at risk based on what you see. And then the second is be more systematic about what you do once you identify those patients as being at risk.
We have everything in one document. So for primary care and GI to manage the NAFL is the at-risk NASH. So the at-risk NASH are those with NASH and stage 2 and fibrosis, which will require treatment now, but in the future we'll have FDA drugs approved based on this NASH and F2. And in our algorithm, we define methods that you can identify these patients.
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and this week's guests, hepatology researchers and key opinion leaders Drs. Michelle Long and Mazen Noureddin, as they discuss Michelle and Mazen's recent paper on best practices in lean NASH on Surfing the NASH Tsunami.
Okay, so it's August. I don't know quite how hot it is in Europe this week, but I was talking to a friend in France on Friday who told me that she was in her mother's house where the temperature was 43. For those of you who can't do that translation in the States, that's about 109 and had no air conditioning. I can't imagine how that worked. Louise may be able to tell us a little bit about the UK version of that in a couple of minutes. The Premier Soccer League has started, and we are here with a fantastic episode today. 2 good friends of the podcast, Mazen Noureddin and Michelle Long, for reasons having literally zero to do with this podcast, collaborated on a really important paper on best practices in lean NASH, a drum I've been banging roughly since we started doing this over 2 years ago. So I'm delighted that they were able to make it today and come talk about their paper. Jorn is still on vacation. Louise is still with us. And with that, why don't we just get started? Groundbreakers, everybody. The one good thing, personal, professional, in the last week. Brave one, go first.
Sure, I'll go first. I had a great week, family vacation. My 2 kids and husband, we went to South Dakota and explored the Badlands National Park and Custer State Park and Wind Cave National Park. So it was great fun, a little hot, but we could just escape to the cave when it got really hot. So that was good. And it was really a beautiful part of the country that I had only very briefly been to before. So it was a lot of fun to see that area of the country and see some really cool wildlife as well.
So when you say escape to the cave, how exactly does that work?
Well, in Wind Cave, it's always like 53 degrees year round. And there's another cave as well, Jewel Cave, which is a national monument that also is like 49 degrees. So on our hottest days, we went and did some tours of the caves.
That's amazing. That's better than air conditioning. That's better than anything. I mean, did you like step in wearing shorts and a t-shirt and immediately get chills? Or
we were gloriously freezing. It was amazing. It was like exploring craters of the moon. It was really, really wild. Highly recommended.
Thank you. Mazen, you go next.
Sure. It was a fantastic weekend. It was Naya's birthday, start with an N. And Naya is my oldest daughter. She turned 4 yesterday, and we had a birthday party in my new house in Houston, Texas. So, when you have a new house, you realize that you're missing a lot of things. So I had to go shopping in the morning for multiple things, including extra chairs, because we had 20 people over. Most of them were kids, so you can imagine the noise in my house yesterday. And then my wife had to go at the end, drop someone off, and I was overwhelmed with the amount of cleaning we have to do. And I had this norepinephrine or epinephrine, whatever you call adrenaline or whatever you call it. And before my wife came back, I did 3/4 of the work. So she was very happy to see the cleaning on my side.
She's going to expect that every time.
Well, maybe I should drop these people off next time.
Yeah, I think take the lift the next time. That's probably a good idea because you can't drop the percent. You've already set the expectation. You can try to redefine it, but I'm not sure how well that's going to work.
It was just anxiety. I looked around me and I'm like, oh my God, what just happened? I babysat the 14 months old. So I just put her in a chair, I gave her milk, and I was just going back and forth like a maniac, rushing to get as much done as possible. It was quite a scene.
So the joke in our house is that I might clean up, but when I'm done, my wife has to clean. Did you clean so thoroughly that she did not have to redo any of your work, or did she have to then do the final touch on?
You sound like reviewer number 2 now, Roger. It's like, stop picking on me. I just cleaned 75%. Give me the 75% and don't ask
I'm giving you
questions like this. I clean well, man.
I believe you. Okay, Louise.
I suppose my professional one was back off holiday, getting back into scanning, seeing some people in clinic last week, which was great, seeing some livers that had changed for the better and one that hadn't, but I'm sure they'll get on top of that. But my personal was I did a helmsman's course for a motorboat at the weekend and managed to pass that. So I managed not to crash into any other expensive boats, which is always a good outcome. And the Premiership's back, so we can all get agitated and irritated.
I think I heard the next time we come to London, you're taking us down the Thames.
Yeah, you never know. You might be lucky. But yes, and the Premiership back, so that we can all moan and groan and get frustrated and send our blood pressures up is back. We torture ourselves, but it's great.
Well, I was devastated by how good Arsenal looked until I saw how good we looked. And then I said, okay, this might turn out all right.
Yeah, my B team, Crystal Palace, didn't start so well, but had they have taken their chances, it would have been 3-2.
But, had Arsenal taken their chances and Crystal taken theirs, it might have been 5-3. Who knows? Look, Arsenal, I have to admit, Arsenal looked good. I don't think they looked quite as good as we looked, but then again, we were playing completely different teams, so who's to say? At any rate, I will share with you mine. I also had a fantastic weekend. One of my guilty pleasures is I'm a big fan of drag shows, and particularly RuPaul. And RuPaul's show was in Philadelphia on Friday night, and it was one of the most over-the-top things I've ever seen in my life. Over-the-top, not in terms of being inappropriately bawdy, but just in terms of sound effects and music and lights and all that. And my wife is actually a bigger fan even than I am, and we were totally blown away by the experience. And then English Premier Football started this weekend, and Tottenham sits number 1 in the league today, based only on goal differential. But they did a very Spursy thing. They gave up a goal in 12 minutes, but then they did a very, not typically Spursy, but typically Conte, our new coach, thing, and scored 4 goals and were just totally dominant and probably could have won by more than that. All right. With that, why don't we move on to our episode? As I mentioned, I skim a lot of journals, and unbeknownst to me, I'm skimming and I noticed this best practices article on lean NASH from Mazen and Michelle, and I said, oh, perfect. This is a subject I care about, and people who've been fantastic guests on the podcast. So let me ask you folks to just start by talking about what was the impetus for you to put this together.
I think we were asked for it, which we were quite excited about. I was excited about working with Michelle. It's the American Gastroenterology Association. They have been putting out a lot of these documents and papers, and I thought it was brilliant of their side to address this or tackle this problem that is prevalent, including the United States, not just Asia as people think. And when we got the invitation, I said yes immediately. We got to work.
Okay. This is a little different to me. So what does it take to pull together a paper like this?
Yeah, it takes a lot of coordination. I think we had an outline that we started with, and we thought about what really is going to be practically helpful. And that comes a lot from our own clinical experience and the kind of questions that we've had to address when we're seeing patients with suspected fatty liver disease who maybe don't fit the classic phenotype and are lean. And also just observations we've seen from looking at the literature. First of all, there's a lot of papers who use different definitions of lean, or they'll interchange non-obese with lean, and those mean different things. So first, we started with kind of getting on the same page around what are we talking about when we talk about NAFLD.
It struck me that the first best practice being, let's all get on the same page on what BMI we're looking at. And I said, boy, that's an interesting place to start, right? It's like where everybody should start, but you assume people are common. So they weren't. Okay. And then from there, what did you settle on early as being key points to address and things we wanted to make sure that people, or you wanted to make sure that people were thinking about and doing properly?
One thing I really want to go back to is the definition of BMI. And I'll let Michelle does that because she was very precise when we started about that point. But in general, that the document summarizes best practice advice. And we had 15 of those, and we started outlining those as the foundation of our work. And then when we reviewed it with Joseph Lim, or Joe Lim, who was our co-author from the AGA, then you send it to the AGA, I guess, scientific committees and reviewer. And they have their reviewers' input, recommendation, and it builds the foundation. Of course, when we had the 15 best advices, we did a review for the entire literature. So the work was kind of done in terms of literature review up front to make sure we're precise with these 15 advices. And then after it was reviewed by the AGA committee, we got them back. And this is when we actually translated what we looked into the literature into words.
So, Michelle, walk me forward in the process from there. You get the paper, you got the 15 things, and now walk me forward.
This is a broad topic, obviously. It's a whole, how do you approach people that are lean with NAFLD? So we wanted to, first of all, talk about the definition and talk a little bit about the epidemiology and what we know about the natural history, and then more information about how do you actually diagnose, what are the other conditions that you want to think about when people present who are lean with suspected NAFLD, and then on to management, because there are definitely nuances in taking care of people that are lean. Because, our standard approach of diet and weight loss needs to be thought about in this particular context. So that's how we kind of came up with those 15 best practice points. And we actually came to pretty quick consensus on that. It was very helpful to have that done first, and then we went in and did a deep dive in the literature to provide background around those specific points. So that was the basic process of how we went forward.
Okay. Anything surprise you as you conferred together on this and went through the literature and all that?
I mean, it sounds like saying no could be a little bit too confident, but probably no, because I think Michelle and I, we have been doing this for a while. I speak for myself at almost a decade, and I'm very focused on the topic. And I want to bring up one of my early cases. I had two brothers from India that came to my office. They were lean, and they sat down in my office and they were frightened. And I started talking to them. One of them had F3 at age of 42, and the other one had no fibrosis at the age of 38, I think, and they had biopsies with NASH. As I said, the 42 or 43 years old had F3, and the 38 or 39 had no fibrosis, which I thought initially like he was scared because of the F3, but then I learned that a brother of theirs died in India. They were here visiting in the US. The brothers of theirs died in India, and he was slightly older than these guys, I think 46 or 47, died of NASH cirrhosis. That's quite an early age to die of NASH cirrhosis. And I guess I don't want to call it NASH immediately on these guys, because then it stimulated my curiosity. Is there a secondary cause? Why these people are having it at such a young age? Are there hereditary things, genetic things, other underlying etiology, which we emphasize on greatly in this document? This is the difference between a straightforward document on your conventional, typical NAFLD patients versus those lean. You have really to pin it down, make sure that you're not missing something else. We say do liver biopsy if you're not sure here. There is a nice table that explains many secondary causes of non-alcoholic fatty liver disease and NASH that I think we take it in greater consideration than in your typical NAFLD screening guidance paper. So there's a twist. There is some art into these patients. It's both sides. The one side is if they're lean, that doesn't mean that you should ignore them and not screen them like what happened now with the new documents with diabetics and metabolic syndrome and all this, and we can get into the details. But at the same time, we're saying make sure you're not missing something else, and those are the conditions that you have to focus on and probably do additional work on such patients.
So, Michelle, you were nodding as Mazen was speaking. Anything in particular?
We spent a lot of time on the tables and figures for this paper, because the goal, knowing our colleagues, our busy clinical colleagues out there, will maybe only have time to skim through the recommendations and look at the tables and figures. And you can get a lot from just looking at that in this document. Not everyone who comes in with suspected NAFLD who's lean needs to have every test measured. So we wanted to provide sort of a stepwise approach. And you can see that in our table where we describe 4 or 5 tests that are in the top part of the table. These are things that really should be considered in all patients because of how common they are and how easy they are to consider, such as covert alcohol use, for example, or hepatitis C, genotype 3 in particular, which often has fat. So some simple considerations there. And then the bottom part of the table, we provide a lot of clinical information about different scenarios that you might take you down a different path and help hone your diagnostic tests. So if they're thinking about a lipid disorder or other metabolic disorders that might contribute, or, even pregnancy, where you might have special considerations. So these are things that, depending on the clinical context, you want to consider in your patient that you're trying to figure out what is driving their fatty liver disease.
I thought it was an excellent piece, and I thought there was a lot of synergy, obviously, with the other guidelines, so that we're trying to there's a definite move, obviously, that you were trying to mirror what is already out there. So there's a consistency of message, whether or not you're non-lean or lean NASH, which I think is great, because most of the people I know who are slim with NASH, people have never really looked at it in the past. They've never even thought to look because they look slim, or they go to the gym or other aspects. But did you think, or is there enough data there to split out the Asian population? Because obviously Asia covers a vast set of continent, from Indian subcontinent, Bangladesh, Pakistan, all the way through Japan and down to the Vietnamese and that type of Asia. Was there a difference or a delineation in people's risk factors within the, again, subcategories within Asia? Because Asia is a big group.
Yeah, that's an excellent point, Louise. We really don't have that granular detail at this point, unfortunately. That's definitely an area that we'll need more information as more studies are done worldwide with diverse populations. It's incredibly important. We do talk about the different BMI considerations, different lower cutoffs for people of Asian descent, but you're right. I mean, that's incredibly broad categorization. So hopefully in future iterations of this, we can get a lot more specific.
Yeah, I want to echo Michelle. A lot of our literature actually came from Asia, like for instance, the 3 to 5% recommendation of weight loss. Although people say they don't have much weight to lose, a lot of them you see like there's improvement with that 3 to 5%, and this is based on a study done by Vincent Wong, and it showed that it helped these patients with their alcoholic fatty liver disease. So again, to emphasize, a lot of data came from Asia, but after this document or toward the end of it, which we did not include, that we just published a paper from the NHANES data on Asian American and hepatology communication, showing that Asian Americans, that they tend to be more lean, which is not surprising, but also they did not necessarily had less fibrosis or advanced fibrosis than the regular non-lean patients or normal weight patients. So there are data emerging. As Michelle said, we need more and more from Asia, Asia had a lot, but we also need it from the West lean as well. There are papers that came from India on lean NAFLD, one published in Hepatology a few years ago, and it was quite informative. I also want to go back and comment on your first comment that there's a lot of synergy with other guidelines, but I also want to mention a couple of things in our algorithm that I think we're proud of. So the algorithms start by recommending, for instance, screening for lean patients in certain condition, which is high risk. We used the type 2 diabetes patients, and we chose an age of 40 based on cost-effective analysis data that came from our group and published in Gastroenterology. We go through the same algorithm such as FIB4 and then followed by FibroScan. And let me start telling you about slight additions, I would say. We made the ELF test more clear here, as with the AGA documents, it was still not available commercially. Now it's available commercially. And I think the piece that we really went beyond what the previous guidelines is the left side, or wherever you will be looking at the document, or the green part of it, which is in the previous documents, they talk about screening, FIB4, then FibroScan, and then referral. And it's mentioned that if you are in the indeterminate zone, you you might want to confirm the fibrosis with either liver biopsy or MRE. The step that we really went beyond, so we have everything in one document. So for primary care and GI to manage the NAFLD is the at-risk NASH. So the at-risk NASH are those with NASH and stage 2 and fibrosis, which will require treatment now, but in the future will have FDA drugs approved based on this NASH and F2. And in our algorithm, we define methods that you can identify these patients, which is a little bit beyond the recent documents. So we talk about the FAST and we talk about other scores and other tools. There's FAST, there's the MAS score by MRI, there's the MAFIB score by MRI, there's the CT1, the multi-parametric to identify those with NASH at-risk NASH. So we go a little bit beyond that. The document has certain amount of words, so we try to be concise and provide the most evidence. But I think we're particularly proud of that step beyond to manage them in secondary or tertiary care centers or GI offices. So that was that in the algorithm. We try to be more inclusive.
I thought it was very clear, and I think that's a beauty of the piece of work. But the other thing that you went beyond where everybody else does is the recommendations of reviewing with FibroScan or MRE. It was 6 months to 1 to 2 years, depending on the level of fibrosis. That to me is important because when we look at non-lean NASH, those recommendations of 3 to 5 years are a little bit long for people who may progress fast. That was another area on this that I absolutely loved. It was clear, it was concise, it was about allowing stratification of who was more severe to look more frequently and to really reinforce any behaviour change. It came within that section as well. So all round, it's gone beyond some of the other documentations, but it's quite short, it's very concise, and it's very clear. And I think that's the beauty of it.
Oh yeah, I agree, Louise. I mean, I think that we thought about what should be the interval following up, and it just went back to how we practice in our clinic. And, if you say someone, okay, look at this again in 3 years or 5 years, with the current level of knowledge of where it's at, it's just going to get lost. It isn't going to be prioritized at all. And it really doesn't take a lot to risk stratify someone. These are very routine tests. FIB4, you probably have what it takes to calculate a FIB4 if you've done standard labs with your doctor. So we recommend that it's done on a more routine basis and even allow for, on a yearly basis, because people need to have a routine in order to remember how to get something done. And since it's easy and not very costly, probably free because you're already getting these tests, then it totally makes sense to just get into the habit of like, okay, I need my yearly liver check.
Absolutely. But it also gives patients to say, I haven't had my screen. I haven't been tested. It gives them information that allows them to help prompt progress and not get lost. Jean was talking the other week about how many people fall off the pathway. People don't get letters, people don't do things like that. But when you tell somebody 3 to 5 years, it doesn't strike as that important in my life. If you tell them 6 months to a year, it racks it up automatically. It's something I've got to be aware of now. And I think when we talk about people taking control of their own disease, these sort of guidelines do make it very clear. And they're concise. Primary care, secondary care, tertiary care, anybody can follow them. Again, that's the beauty. It makes it easier. Certainly in third world or developing world countries, some of these can be utilized if they don't have some of the other more expensive technologies, for example. Again, that's about adapting this process and framework to where it can be effective most.
So, Louise, you make an interesting point, which is, in response to Michelle, if we should be looking at lean NASH every year, would that suggest that despite the 3 to 5 year recommendations on NASH tied to obesity or overweight patients, that we should be evaluating their livers every year as well? Would that be your suggestion, or is that how you practice, or is there something that makes this special?
Let me take a jab at this so we don't get controversial, and I'll go back.
Controversy is a good thing, Mazen. It's a podcast.
So I don't want to... I want to use Michelle's comments. Let's see what we have on FIB4. I think it's a great test. It's a cheap test. You can repeat it, as Michelle said, whenever you want in your office. There are also data that suggesting it might not be as good in type 2 diabetic patients. We need more research on that. There's data showing that people in the indeterminate zone and low prevalence zone, there's still people that they might get in trouble. So The thought was just, if I have a patient who's already, I'm probably puzzled why he has NASH, but we know now that's quite a bit entity, that lean NASH, and I'm ruling out other causes and then I diagnose them with NASH. Rather than waiting for 3 years based on maybe one FIB4 test if other documents say so, you can repeat it sooner because it's just sitting in front of you and looking at you is like, calculate me. So we just wanted to provide shorter interval. I mean, put a stethoscope on someone 6 months or once a year is easy. Then FIB4 is that easy to calculate. So that's why we went for shorter interval. And I still think the other documents are outstanding. It just makes me nervous to repeat a test in 3 years from people memory standpoint and the primary care standpoint and from practicality standpoint. Don't forget that all the diabetes workup is usually done on a yearly basis. So you just can tag that along, and while they're getting their retina check or their UA check or something, whatever they want to do, you can do it at least on a yearly basis.
Okay, I'll be controversial. I believe that the reason that the 3 and 5 year recommendations are given is because it is an effort to calm the fears of people, most of whom are payers in some way, shape, or form, that if we test this every year, oh my gosh, what does that tell us about what it's going to cost, what we're going to find, blah, 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 blah. Not necessarily through a patient-centric window. Through a patient-centric window, I get where you're saying, if you're doing yearly checkups with people, and this is FIB4 is an easy thing to do, why wouldn't you just look at it yearly? So that was the first question behind my question. And there, I agree with you. I think it makes a lot of sense.
And I think it should be patient-centric. Of course, you don't want to do something not cost effective. I have done a lot of analysis on cost effectiveness. We have not done one repeating it every year in particular, but I can tell you from now, just simple math, it's going to be cost effective to repeat it probably every year.
Okay, so that makes sense to me, number one. Number two, the first time I really, remembering that I've been involved with NASH for all of 3 years, when I first became involved, I remember going to a investor meeting and having one of the keynoters was a guy who'd lost his mom to lean NASH very quickly. And after doing a little bit of digging around, I came to the conclusion that either the pathogenesis was faster or because we weren't looking, we were picking people up way too late, but that on a per patient basis in the States, lean NASH might be more expensive, might be expensive faster because the progression was faster or we're picking up late, then we're going to be spending a lot of money on patients once we picked it up quickly, and that was being overlooked. And when I raised that with people, they were kind of touchy about it. So I'm wondering whether anything about pathogenesis or disease progression went into your thinking about frequency of testing as well as simply the idea that it's a convenient thing to do.
That's a really good point, Roger. And, we did talk about this a lot in the earlier, I think it's BPA, the best practice advice number, maybe 3 and 4. People who are lean, who have fatty liver disease, often have less severe phenotypes when they present, but they actually progress and have liver-related outcomes, sometimes even in some papers, even more frequently than those that were not lean. So I think we're just scratching the surface of the natural history and trying to think about this as a potential subphenotype of fatty liver disease. There's been a lot of effort and we have a lot of literature now, but there's still a lot that needs to be done to fully understand. The biggest thing that I see clinically is patients who come and say, oh yeah, I was told I had fatty liver disease, and then my doctor did an ultrasound and then they said I'm good. And what is that supposed to mean? You're good? Done, check box forever. That's the end of it, and not even doing the appropriate risk stratification test. So, in particular, when someone is sitting in front of you and as a provider, providers are busy and they have little time and they need someone who looks lean. It may not trigger in their brain that this person could have fatty liver disease. And so we, in particular, want to caution providers in saying this is not necessarily a benign condition. You need to do the work to help understand where your particular patient sits on the disease spectrum. You need to break that bias that you have when you're looking at your patient saying, oh yeah, they're totally lean. I have patients who are looking very different than them, and really trigger that. We're hoping this document helps trigger that they need to have that conversation. Just because someone is not obese or is not overweight doesn't mean that they're off the hook. And we've seen this now in the natural history studies that we do have, and hopefully there'll be more coming out to kind of add more details onto this.
So the last two things that we've recorded, one for Surfing NASH and one for the Rising Tide Diabetes series, have been roughly in the neighborhood of this conversation, but not exactly. The last Surfing NASH episode, Louise and I spoke with Ian Rowe about a poster he presented at ILC. The poster was about early diagnosis and the most cost-effective way to do early diagnosis and capture patients, and it was decision curve modeling. What they suggested is, and this is for total population, which means a lot of people who are obese or overweight, is that you could pick up 85% of cases more cost-effectively if you used what they call the fibrosis first method, where fundamentally, now their goal was to identify people with clinically significant fibrosis, but it was a more aggressive early testing regimen. It wasn't as comprehensive as ILFT, for example, but it was a lot less expensive. I'm wondering if now that's an approach that you could take before anybody got near a gastroenterologist or hepatologist. Lean NASH, how do people come to you in the first place? Because I assume that kind of a holistic approach, or ILFT, which is targeted at primary care, those kinds of approaches might not make sense here because you're dealing with, unless you're in Asia, you're dealing with a relatively small percentage population.
I can answer from my clinical practice. The lean NAFLD and NASH usually come, which is slightly consistent with the literature, for persistent elevated liver enzymes, especially on the higher side, meaning 30, 40 will get ignored, 50 will get ignored, but if it becomes 80s and 90s, and there are published data on that, this is when we get the lean NAFLD. I don't think I got a referral on, or maybe not as many, on lean NAFLD who had abnormal imaging with ALT of 35 or 40. That's what PCP they do. And that's why in this document, we went systemic and we recommended for evaluation for metabolic cofactors in lean NAFLD. And we recommended screening for lean NAFLD in lean people with type 2 diabetes and age 40 and higher. I hope that answered your question, Roger.
Yeah, I can add to it as well. I definitely agree with Mazen. That's most of the patients with lean NAFLD that I take care of also present in that way. Occasionally you'll have someone who had an ultrasound for some reason, and they incidentally were noted to have hepatic steatosis, and that was surprising given their body habitus and comorbidities or alcohol intake. And so they'll come in through that way. And then the other way, unfortunately, is just people presenting with complications of cirrhosis. And that is also probably most of my lean patients have decompensated cirrhosis, and they presented with occult liver disease, with variceal bleed, or developing ascites or some other complication, unfortunately.
So unfortunately, you now reminded me of what my other question was, but you did so in the process of answering it before I asked it. So thank you. That's great. My take on your collective answers are that a general screen pushed back to endocrinology or primary care would encompass the type 2 diabetic patients, whether lean or not. And the other ones are just going to be a lot harder to find unless their liver enzymes are persistently really elevated, and then they'll wind up in hepatologist anyway because no one will know what to do with that. So you probably don't need any special screening steps to capture lean NASH in a primary care or endocrinology population beyond what you would have them do if you were simply going at patients at high risk. And it's when you get to the hepatologist. So the part that's in the blue basically is about how to get someone to a hepatologist, and the hepatologist really has to pay attention. Am I reading you right?
Yeah, absolutely. I'm intrigued by your comment about Ian's work. I'll need to look his poster up or listen to the podcast. But this idea of doing fibrosis first and having that level of risk stratification happening before the hepatologist makes a lot of sense. But I think in order to get there, we need to get people really comfortable thinking about fibrosis and really understanding these tests. And my experience has been that people get really nervous, providers get really nervous about the liver and feel generally uncomfortable. I think we can get there, but we have a lot of work to do to get people comfortable assessing and evaluating for fibrosis without involving a hepatologist.
Would it be more getting people acceptable and comfortable assessing for liver health rather than fibrosis? Let's actually check the health of the liver. We have transient elastography. We have a number of other tests that act like a stethoscope. Some of them are accurate. Some of them are less accurate. But it's that comfort. Your body, by definition, defined the liver as the most important organ. It is the only one to regenerate. No other organ does it. So by genetics and that, for me, I'm simple. If it ranks up that important that you have to keep it going, it has to regenerate, it has to be up there. So getting people more comfortable with that whole thing of rule it out, don't rule it in. So therefore, Ian's strategy would work in that sort of line. Going back to what Mazen, and it was part of the question I was going to ask, was if you screen people or check them more frequently, you can discharge the ones who've made the change and no longer have NAFLD, rather than keeping them in a pathway for 2 to 3 years years while you continue to gather more patients. That's, again, how we can keep them in. I know in the UK, for example, our model is if you must see a consultant once a year to stay in the NHS system. If you DNA that appointment or miss that appointment, you fall out and it all starts again. So when we talk about following up with these tests 3 to 5 yearly, we are going to lose just by pure attrition a lot of people. So again, keeping them in the pathway, assessing more frequently, yes, it is a cost, but for everybody you discharge, you're cost saving. Certainly I've read some of Mazen's work on that, and yes, type 2 diabetes over the age of 40, no brainer to me, but I love liver health. For me, it's about poor health. Most people have poor health. They don't necessarily have fibrosis or liver disease, more metabolic, endocrine, and cardiac. That, to me, seems that we would try and locate a lot of the lean NAFLD, because they weren't small numbers that you talk about in this pathway and assessment. So we just don't get to see them until they present too late.
Yes. And to add, Michelle, his definition of fibrosis first was simply liver enzyme tests, virus serologic screening, iron, and FIB4 would actually qualify as fibrosis first. So what you're advocating doing every year is, now he gave the option of doing VCTE at the outset, and part of our discussion was about the benefits of doing VCTE at the outset as compared to FIB4. But you could certainly, I mean, Louise, if I've got this right, if you remember something I do, FIB4, what they're recommending would fit into his definition of fibrosis first.
Yeah, it was a routine screen, more of the more common liver diseases to rule as the base screen. And if you then had a problem, to move on to more detailed screening, obviously in the light of fibrotic score.
Mm-hmm. Yeah. So
yeah, I love it. I think that's great. All the efforts that we're doing to help get our primary care, endocrine, cardiology, other subspecialists comfortable with FIB4 will go a long way.
So what else would a listener who was a hepatologist take out of this conversation and this paper that they might not be doing now? How will it change what they do? And then I'm going to work back to a gastro, and then I'm going to work back to everybody else.
Hopefully our hepatology colleagues are already doing these things, but I do think it provides a nice framework to think about this issue. We point out specific areas that we need more information, in particular the genetics of lean NAFLD. There are a lot of papers that are showing kind of opposing findings. It's pretty confusing literature, and we were not there when we reviewed the data. We're not there in terms of recommending any kind of genetic risk stratification. I think that's how people are practicing now, but it is definitely a call for more research, in particular in that aspect. We need large cohorts of well phenotyped and genotyped patient populations that include lean patients with NAFLD in order to fully understand the genetic underpinnings of this subphenotype.
I think also to add, I want the hepatologist to read table 2 in particular. I think a lot of times we might forget other causes of fatty liver or non-alcoholic fatty liver, especially in lean people. And in table 2, we give a list of, not just a list of the conditions that you might think of, but also how to suspect them. Wilson's, probably a lot of people don't forget it, especially in lean patients, but it's there. But for instance, urea cycle disorders. So it tells you when to suspect it and how to do the workup. Other lipid abnormalities, hypovitalipoproteinemia. For instance, you look for low triglyceride, stuff like that. So I think that table can be very helpful for the hepatologist to go back and look at it when they have their non-alcoholic fatty liver disease patient. And I think some people, although people started doing the fast, some people are still not doing like MRI scores, and I think they're becoming more handy in clinical trials than others. CT1 is another example. So it just explains where are we with the most updated science in hepatology and GI clinics. So in my mind, this document includes both primary care and GI and hepatologists. So the GI and hepatologists can go to primary care people and say, look at this blue part, this is what you probably want to do. But also it gives some directions for the hepatologist, what is available nowadays to narrow down their list of patients that needs to be treated. One important consideration in NASH patients that we put here, and we got questions about this, we use the traditional treatments such as vitamin E and pioglitazone, and of note, we probably can benefit from more studies in lean NAFLD NAFLD or lean NASH on these conditions. But also, whenever I get a lean NAFLD or NASH patients, the 3-5% weight loss can be really important. But I find like referring these patients to clinical trials is really helpful. It's good to include them in NASH studies. They will study the natural history, will test the medications on them. So clinical trials, and it's a very important consideration in these patients. And to get these patients into clinical trials, you have to know how to tease out at-risk NASH via FAST or these other new tools.
Can I ask you, your best practice number 6, the clinician should query routinely regarding alcohol consumption. I thought that was quite controversial. Not the questioning of the alcohol intake. It's a sugar drink and it's alcohol, but the testing of somebody who you think is probably not necessarily telling you the truth. I find that uncomfortable, that if somebody's going to lie to me or not to be fully disclosed, I can only give the best, or you guys can only give the best information and advice based on the information you get. But then doing additional tests to prove that to me sits uncomfortably in that whole practice provider, honesty, trust scenario. How often do you think that will happen? Is it really something that is going to be done? So that to me was the only controversy throughout the documentation, because as I say, it sits uncomfortably with me. This, you told me this, but I did this test. It says something different. That's not a nice place to be.
Yeah, again, it comes from, in general, NAFLD and NASH is less suspected in lean people. And we put great emphasis on, because they are not your traditional overweight, type 2 diabetes, hyperlipidemia, multiple risk factors, we put emphasis on not missing anything. And as a pathologist, misreporting or not reporting the real amount of alcohol intake is a problem. And we encounter that every day in our practice. Not necessarily all patients, probably on the minority side, but there are patients like that they don't report it. And this is what we leave it in the document. I guess we leave it to a great detail in your clinical suspicion, and that we give options for tests that emphasized on other documents on what to do. And this is part of the job as a hepatologist. You have to walk that uncomfortable walk, and each one has a different way of determining how much they drink, and they are not necessarily like the right way or the wrong way. There are different clinical approaches and bedside manners and approach that hepatologists follow, but it's important not to make sure people did not Google something and they coming to you and they telling you I have non-alcoholic fatty liver disease, and they're not telling you the truth. And we know that sometimes in clinical trials later on we find out that they drink more than they were supposed to, and maybe that was not the right patient to include. There's a paper that came on JHAB that showed a lot of NAFLD patients had positive alcohol testing. So such a paper will support our recommendation that you may consider these tests when you have a clinical suspicion.
Oh, absolutely. They're just not the most comfortable place to be. And I suppose the old rule of thumb was you half what the relative tells you and double what the person tells you. But in fact, there was a really good presentation in one of the breakout seminars at ILC recently. It was on, and Roger, you were there, it was on hair, using hair. It gives you a longer period of time, particularly in relation to clinical studies, as to how the effect was on that clinical trial, because you can date it back a long time. So it's a controversial area, but it's an area of great need, I suppose.
Let me note that the CRO executive I spoke with immediately after that presentation said, gosh, that'll never happen. By the time you get the answers, you can't do anything with it except maybe disqualify a patient. You're already qualified, and I'm not sure how that would work. So,
or people will start shaving their head.
might be a new business for clinical trial sites, right?
You don't need to ask the question.
I think the point also with the best practice advice number 6 around alcohol is that we really need to get this conversation happening. And it's not okay just to say, oh, you don't drink that much, right? Or making assumptions about our patients or feeding them answers. We really need to have conversations around alcohol. Patients report that they do not get asked about alcohol in any kind of detail. Maybe that's true, or maybe they're not remembering it, but it really needs to be something that is discussed. And we go into suggestions, and actually some of the work that I've done in the Framingham Heart Study, where we look at different patterns of alcohol use as well. Because when you're really scratching your head and trying to figure out what is contributing to this person's liver disease, understanding maybe it's how they're drinking alcohol, they're having a lot of binge drinking behavior, or frequent having many drinks in a short amount of time, or those types of patterns, they may be more associated with liver fat. And so this is something that a highly motivated patient can change and alter how they're consuming alcohol, and that may make a difference in their liver fat.
I think that's true, but you also see the opposite stigmatization. If you're overweight, it's all food. If you're slim, it's always alcohol. And treading that line carefully, and it is an important discussion to start because, as you stated earlier on, very few people who are slim get ever asked about their diet. And yet, because they may have lean NAFLD, I've seen a lot of early 20s, late teens, very slim, just awful college diets, and their livers would suggest that. So it's about education and that discussion at that time.
Yeah, absolutely. I mean, this document, we're talking specifically about lean NAFLD, but everyone with NAFLD, needs to have a discussion with their doctor about alcohol use, because it's definitely a part of the condition that we are probably under considering for the most part. On the other end of things, we have patients who come in and they're like, look, I swear I don't drink. My doctor has sort of grilled me on this and I'm feeling very uncomfortable. And then, it may be nice to say, look, let's measure one of these really sensitive biomarkers and kind of prove it to your doctor as well, and kind of take it off the table. So that's a nice option as well, where patients can say, look, I want you to believe me and I want to kind of move on from this and really get down to what is actually happening in my liver. And it can be nice and that's why we kind of make these suggestions for other tests that may be helpful in just taking it off the table.
So we're kind of at the bottom of the hour, and I think I'm pretty much out of questions for right now. Closing question then. Two questions, actually. What is the one most important thing you want a reader to take out of this article, conceptually? And what is the one most important thing you want them to do differently as a result of having read it? Michelle or Mazen, whoever wants to go first.
The most important thing about this article, I would say, is that there are special considerations in people that are lean who have suspected NAFLD. So look at the tables, look at the algorithm. We provide a lot of guidance and support. We know clinicians are busy, so we want them to look this over and be really systematic in how they approach patients with lean NAFLD. And that gets onto, what we want them to change, I would say. It sort of depends a little bit on who the audience is. For primary care, non-GI hepatologists, we want you to recognize that lean NAFLD is an important condition. Patients can progress and have liver-related outcomes, and this can, unfortunately, they often present late because it goes unrecognized. So follow the algorithm. We provide information about how to assess for more advanced liver disease and how frequently to do that. And then if you're a subspecialist GI hepatologist, you can also think about what other conditions need to be ruled out. Some more rare conditions in the appropriate clinical context may be appropriate to kind of work up. Going back to that table too, everyone should have assessment for the more common conditions. We provide information about how you can confirm the risk stratification that hopefully has already started before you're seeing the patient using non-invasive tests, and how frequently to repeat those assessments.
Great. Mazen?
I cannot add more to that. I think that's perfectly said.
What was that, Mazen? I'm perfect in every way?
Yeah.
Yeah, and not only that, but you know how to stay cool in July in South Dakota. Really impressive things. You've covered the entire landscape, and then you get to go to Copenhagen this week. You've got it completely covered today, Michelle. This could be a Sir Galahad kind of moment.
and I got only 75% done in half an hour, so I couldn't do it 100%.
So, Louise, your thoughts?
The most important thing I think that people need to realize is to ask that question about diet in everybody. It doesn't matter what your size, your shape. If you are talking to people about their diet, particularly high sugar, fructose, alcohol is sugar, their sweetened beverages, the honey that they add to their tea. If you're in the Arabic population, most of the people that I've met, they always love adding honey to their lovely black teas and things like that. So just asking those questions, there will be flags in everything that somebody says, whether it's lean or non-lean, but particularly with the lean NAFLD. And I suppose the one thing I would like patients or even nurses who are seeing patients in clinics to take away is A, the diet, but B, if you've got a patient there who's slim with type 2 diabetes, ask the question. Really be probing that little bit more because of their history, because of their likelihood, and particularly if they're of any of the Asian races and ethnicities, because they have higher risks. So again, it's all around the diet. If it becomes a simple question within everybody's assessment, then we can pick out things. There will be red flags, but those were the two really big things for me. And also that framework that a patient can use to say, I've been picked up in the past with a fatty liver on scan. I saw 2 of them last week, in fact, on Friday morning, and both the same, both slim, both fatty livers, both scores on the doors now because it was only an ultrasound. They never had a follow-up. So things like that that are very, very common. We have technologies now that can help primary care manage these people in primary care, keeps it at source, pick out the ones who need more specialist care, and then funnel them. And I think frameworks like this are really, really helpful. And I believe in this, the Stevenism, the KISS. I think this keeps it as simple as it can be to make it doable. And if it's doable and simple, then we should be starting to hit these target populations.
Yeah, that's great. I was trying to do this in a series of 2 to 3 word phrases, and I couldn't quite get it done, but I'm close. The first thing is take this seriously, which has 2 elements to it. Number 1 is think more expansively about what patients might be at risk based on what you see. And then the second is be more systematic about what you do once you identify those patients as being at risk. And I think you've done a fantastic job of laying that out, number 1. My side thought is that and this keeps coming back at me in different settings, and it's significantly unrelated, is about the value of FIB4 until we come up with something better, which is that it's easy to get it into a whole bunch of situations, and while it's hardly perfect and has serious flaws that everybody can identify, it gives us a way in moments like this and lots of others to get to a fast answer about what you don't have to be worried about. And here, where no one's thinking about it enough in the first place, it's just a great flag to have. Quentin Anstey always says, let's not let perfection be the enemy of the good. And this is just one more of those cases where it certainly isn't perfect, but it's certainly really helpful. So unless either Michelle or Mazen has any other comments to make, Michelle has a flight to catch and a new city to go to, new country, new city. And I've never known Mazen to not have anything to do, but he's got 25% of his house he has to go back and clean up from the party yesterday. So thanks, both of you. This has been a fantastic hour. And Louise, thank you so much. And I'll be back with Business Report in a couple of minutes. Thanks, guys. Bye-bye.
And now for the Season 3, Episode 40 Business Report.
Slava Ukraini, Heroyam Slava, glory to Ukraine, glory to heroes. In the last week, there have been maybe some hopeful turns in that war. Let's hope things are going in the right direction and stay that way.
Our CME podcast has soft launched.
We believe our technology challenges are slowly receding in the rearview mirror. One point of proof, we're in the middle of the soft launch for our CME proof of concept episode titled New Data, and ITs can help diagnose and manage NASH patients. We'll begin promotion on LinkedIn and other outlets in the next week. Keep an eye out and listen. It has some of hepatology's leading global key opinion leaders discussing how best to utilize NITs, sharing data on it, and providing practical advice in equal measure. Another innovation, the way you earn CME credit is by answering thought-provoking questions called nudges about how to use what you just learned in your day-to-day practice. It's a lot different than your typical CME test. If you want to access the CME episode and gain credits during the soft launch, send an email to questions@surfingnash.com. I'll send you a link, or go directly to the surfingnash.com website, look for the CME link in the upper left-hand corner, click and follow.
Rising Tide Episode 2 will be out next week.
All right, this is a long business section already, and it's going to get longer. Just know that we'll discuss this episode in greater detail next week when it launches.
We appear to have reached a new level on weekly downloads.
We've just seen our 5th straight week with more than 2,000 downloads. I mentioned last week that downloads for July were 8,876, which was way ahead of our previous best. If we maintain the pace we're on through the month of August, we might reach or exceed 10,000. We'll update next week. Obviously, we're really excited about this. We hope our listeners are too.
One change in the upcoming schedule.
The episode we planned for next week, updating our look at why NASH drug trials failed and what has changed, and will be shifted to the second half of September after our coverage of the NAFLD Summit. We'll have more information on next week's topic to post on our website in the next 2 days. After that, the rest of August will be as promised, and we will be covering Paris NASH and NAFLD Summit early in September. And with that, I'm off. Thanks to the crew, Magic Mike, Eric, Steve, Murph for everything they do. Our new associate producer, Jake, has joined us this past week. You'll be hearing his name in the future, and may even get to hear his voice eventually. It's kind of a cool voice. He's joint U.S. New Zealand national. And that will add one more accent to the collection that includes Louise, Jorn, and my boring prosaic American. Remember to look for ads on the CME episode at the end of this week, or check for the soft launch by finding the CME link on the Surfing Nash website, and check out the episode. We'd like to hear what you have to say about it. And as always, thanks to all of you, more of you than there used to be, for listening and making this such a worthwhile labor to pursue and something that makes all of us so excited. Stay safe. Surf on. I look forward to seeing you again next week on the podcast. Bye-bye now.
Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website.